Services, Office of Mental Health and Substance Abuse Services. It's my pleasure to introduce Dr. Perry Rosen.
Thank you so much, Karen, and good morning, everyone. Happy Monday. I am really excited to be here with you all this morning. The focus, of course, is on comprehensive school-based suicide prevention efforts. And, to what Karen was just saying, I am really looking forward to not only kind of sharing kind of the overview of what we've put out through the state, through our youth suicide prevention grants on what this can look like, but also hopefully hearing from many of you throughout today. I would love for this to be interactive. I know there's a lot that you're putting in place in your schools and your districts and your organizations and agencies. So I really do encourage you to share in the chat. I'll have some stopping points to do that, but really anytime. And any questions you have, feel free to also put those in the chat. I also am happy to be informal. You can interrupt me. I will try to pause for questions. I also was kind of hoping that before we start, if you wouldn't mind, I just would love to know who's here and kind of like what role you represent in your organization. So if you want to say hello, you can put your name in the chat, your district or your agency, and what your role is. I'd like to see that, and I'm going to go ahead and pull up my slides while you do that. One second here. Brief technical difficulties. Hold on one second.
Hi, Tara Cook.
If you're just entering, yeah, what we had asked is if everyone could put their name, Karen's saying hello, their name, their organization, and their role. That would be really helpful. Okay, hold on one second. Here we go. My Zoom just doesn't want to behave itself on a Monday morning. And in fact, I just got a notification that needs to update. So hopefully it doesn't do anything funny while we're going ahead. Okay. All right, so let me go ahead. This is just, so I'm based out of the Children's Bureau at the Office of Mental Health and Substance Abuse Services, as Karen mentioned. A big part of my role, two big parts of my role that I think are relevant for the presentation today. One is that I'm part of our statewide youth suicide prevention grants. So I've been working on those for about 8 years. As Karen, if you were on early, Karen kind of mentioned the last time that we were all together, I'd come out with some of my grant team members for an event similar to this, but it was in person. And that was when our efforts were really focused on schools, colleges, and SAP. And our current grant is focused more broadly across youth serving systems. So we're really looking at continuity of care for youth that are at risk of suicide, as we know that they transition between multiple systems in these pathways to get them connected to care when they're identified as being at risk. And then, of course, also returning back to home, school, and community following some sort of crisis or higher level of care that they may be in need of. So our current grant is working on that. We are using a zero suicide framework, which I will briefly mention in this morning's presentation. And then another big part of my role is that I'm part of the Pennsylvania Network for Student Assistance Services. So I'm proud to be our interagency representative from DHS, helping to oversee SAP in the Commonwealth. So just taking a look at the chat and seeing that it's a very diverse group, which is really exciting, seeing counselors, seeing administrators, seeing some agency staff, some providers. This is really wonderful. So I'm looking forward to this being a rich conversation this morning. And again, looking forward to hearing what you're all working on when it comes to youth suicide prevention. So what I'm planning to cover this morning, firstly, to talk about the essential components of comprehensive school-based suicide prevention, and how they align with multi-tiered frameworks. We're thinking broadly here, and the goal is to really think about sustainability of these efforts and how we're prioritizing these efforts in our schools. So trying to get away from just sort of what we sometimes do by necessity, because we have so much to do in schools, which is a training here, right, an intervention there, a meeting here, but thinking about how these fit within a structure and how we can kind of elevate these efforts and link them and align them to other things that we're doing. Secondly, I want to focus on some key practices and approaches. You'll see that I'm kind of using the language of mental health promotion and suicide prevention. These obviously go hand in hand. When I think about prevention, I don't think about that in isolation. I think about how we're looking at that and all of the potential risk and protective factors that go along with that, and we'll talk about that. And then finally, I do want to share a range of resources that can support you and your schools in your suicide prevention efforts. So you'll see a bunch of links throughout the slides. We can talk about some specific things. I'll have links at the end. And again, hopefully you can all also chime in and share. Okay, so I do want to start by taking a look at the overall suicide rates. Most of you may know that our suicide rates do lag behind by a couple of years. And looking at these trends, we're looking from about 2010, but we can even go back further and know that these rates have increased significantly over the past 2 decades. What you're looking at as far as the numbers on the left, that's a rate. So suicide deaths for every 100,000 individuals, which is how we typically look at rates to be able to make comparisons across different areas and groups. So you're seeing here with the red, which somehow the red disappeared, but the red is Pennsylvania and the blue is the United States. So we're looking at how Pennsylvania rates did surpass national rates starting around 2013, and they stayed above national rates for quite some time until what is exciting to see in some ways, I'll give you some caveats to that, but exciting to see that we started to see some decreases. Decreases actually starting before the pandemic, and then another decrease carrying into that first year of the pandemic. But the caveats, unfortunately, are that those decreases were not across the board. What we know in terms of our data is that groups that were most adversely impacted by the COVID-19 pandemic, mostly populations of color, saw their rates continue to increase into 2020. So it's hard sometimes doing broad overviews of data and not being able to get into some of the nuances. But what I think we've started to really see at a national level is that we can't just focus on our aggregate data. We need to disaggregate that and look at the trends for specific groups. What is really interesting, though, is that we have received provisional data from 2021. We, of course, had hoped that we would see decreasing trends, but similar to other large-scale crises, our data from 2021, which is provisional, is up again by about 4% from 2020. So it's not quite at the level of 2018, and again, still provisional. So it means it's not quite finalized yet, but pretty close. Not quite at the level of 2018, but approaching those levels, and concerns, of course, about those rates continuing to climb, especially with everything we're seeing around the mental health impacts of the pandemic. But if we do take a step back and if we do start to focus on youth, to share some of this data, which I'm sure is familiar to most of you, we know that about 1 in 5 students do have a diagnosable mental health condition, right? And about 1 in 10 do have a mental health challenge. And these data were the same data that we had prior to the pandemic. And we know that these issues have, of course, continued to intensify. I want to share on the next few slides some of the data coming out of the pandemic. And of course, from all different sources, looking at different age groups, looking at the data in different ways. So nothing necessarily kind of coinciding completely, but I think putting everything together is obviously telling us the story that we are seeing these needs and challenges increase. And, you know, it goes without saying that you're all seeing that firsthand within your schools and your agencies as well. So one of the data sets that has been shared, this is actually data that was pushed out by the Annie E. Casey Foundation. They do a kids count survey that has a ton of data. If you haven't looked at that data set, I would highly recommend it. You can actually go on their website and you can manipulate like geographical location or city, and you can pull down all sorts of rich data on lots of different indicators around risk and protective factors. But they did push out some data that was from the National Survey of Children's Health. And so what was seen, they really looked at changes from the survey data from before the pandemic to that first year of the pandemic, and found, of course, not surprisingly with everything we're seeing, that youth across the country and in most states were more likely to deal with anxiety and depression during that first year than previously, right? And even sharing specifically our Pennsylvania data, we saw a 27.5% increase in the number of students that were diagnosed or reported to have by a healthcare provider anxiety or depression. And so that came from just that comparison, looking at those different years and the change there. Not represented here, but I don't know if people have seen a lot of headlines in the news the past couple of weeks pointing to the CDC data. The CDC looked at the Youth Risk Behavior Survey data and looked at trends over the course of a decade up to 2021, and is really pointing to the significant increases in some mental health symptoms, I'll call that my Monday morning glitches, that really are impacting our adolescent girls. So a 60% increase over that time period of a decade up to 2021 in girls reporting that they feel persistently sad or hopeless. And we also are seeing a significant increase in the percentage of girls, adolescent girls in particular, that are reporting seriously considering suicide. So from that data set, it's 1 in 3, so about 30%. So that CDC report and the media attention that was getting really was drawing attention specifically to our adolescent girls. When we also look at some populations at increased risk, which again, before the pandemic, but coming out of it as well, we obviously know that our students that identify as LGBTQ+ are also at increased risk. And the most recent data from that Youth Risk Behavior Survey, which looks at if students identify as LGBTQ, reported that more than 1 in 5 actually reported attempting suicide in the past year. So a little bit more about this population. If you aren't familiar with the Trevor Project, they are an organization that provides a range of resources for this population. Some are just building that sense of community and online forums for youth that identify in this way to connect with one another. Others are actual crisis resources. So the Trevor Project has a dedicated crisis lifeline for LGBTQ+ youth, and they do an annual survey for youth ages 13 to 24. So in this, what you're looking at from their most recent survey data, obviously we're seeing these concerning and much higher numbers when it comes to symptoms of mental health and indicators of suicide risk, considering suicide and attempting suicide. And some interesting points that came out of the survey when we think about the implications for supporting these populations in school. One was it asked these individuals who wanted mental health care but didn't get it, and why not. And some of the biggest reasons that were cited were, one, just a general fear of discussing mental health concerns. So us thinking about how are we normalizing these conversations in our schools. That was about half of the individuals who reported a fear of talking about mental health concerns as a reason they didn't seek services. A close second was concerns about getting parent-guardian permission. And following that, it was fear of not being taken seriously. So things to think about. We do know, though, that this survey also shared a range of important protective factors that we can be thinking about in terms of how are we cultivating these in our schools. So we know things like being supported by others and having close connections. That's a protective factor across the board, especially for this population. And thinking about how we're creating an affirming environment, using preferred names and pronouns, supporting gender expression, all of these different pieces, because one of the things that was looked at was a correlation between items, and youth that reported on this survey reported significantly lower rates of attempting suicide when they felt like they were supported by family and friends. So these protective factors can really go a long way. I want to highlight Safe to Say Something data, which I know you're all familiar with Safe to Say Something at this point. If anybody heard the new governor's budget address, he did mention Safe to Say Something, and he was really present in the Office of the Attorney General when this launched and pushing for this. But the interesting thing is that it was not thought that this system of support and identification was really going to be about mental health. It was thought, and this was put in place following Parkland, the shootings, and the school safety reports that came out at the state level. And the thought was really that this was going to be a way to identify threats to others, threats to schools. Really, it wasn't anticipated that things like suicide and self-harm would stay at the very top of the reasons for tips coming in here. And you see that that is consistent across the board from the inception of this program. I feel like I can't do a presentation without highlighting the Pennsylvania Youth Survey and the rich data that comes from this. And again, we do now have our 2021 data, which is data from the pandemic year. So if we take a step back and we look at some trends over time, we can see what's happening around some of these important indicators. And hopefully you're familiar with the PAYS data. It is a free and anonymous survey that schools can use. And it's available to students in grades 6, 8, 10, and 12. And we're piloting the 4th grade survey, which is very, very exciting. But really, it is looking at a range of risk and protective factors. And so just to highlight a couple of these, what you're seeing here, if you look at like the second row, so the majority of students, right, over 80%, and that stayed pretty stable, they say they feel safe at school, which is really, really important. Safe environments as a protective factor when we're thinking about supporting student mental health and suicide risk. And we can continue to enhance that further, right? Because we know that's such a huge protective factor. But then if we look at the first line, and I kind of put in red there, the indicators that are trending in a direction that we really don't want to see them trend in, right? So most students feel safe in their schools, but they don't enjoy being in schools. And so what does that say for that sense of connectedness? A little bit later in the presentation, I will share a study that talks about the impact of connectedness on suicide risk, a really, really exciting study that only underscores the importance of that, of having that in the school community. We can also look at some of the concerning trends around bullying, right? Whether adults stop bullying when they see or hear it, that is decreasing. And then of course, those mental health indicators that we're seeing there. So those, you know, some of them were trending in a direction that we would hope, right? Around looking at self-harm, that decreased a little bit. You know, seriously considering suicide was hovering for a few years around 16%. But the concern is how they've increased in 2021. And again, this is consistent with everything we've been talking about with the impact of the pandemic here. And then finally, just to hone in on these a little bit more, I just kind of pulled out the more direct indicators of the mental health and suicide risk here, you know, just to kind of reiterate this. And I will say that some of the most significant increases, if we were to break this down, were observed in our youngest students taking the PAYS. So 6th grade students and 8th grade students saw some of the most significant increases from the prior years when we look at these indicators of suicide. So, you know, this isn't something, you know, I know that some of the legislation we have, we'll talk about that. And just historically, some of our school efforts used to focus our suicide prevention efforts at the high school level. But our data is really telling us that prevention needs to start sooner, right? What I also didn't mention is that we are seeing worsening trends for all racial and ethnic groups on some of these indicators. But I just want to call out that Black youth suicide is on the increase, and Black elementary aged youth have seen a doubling in their suicide rates in the past decade and a half. And we're talking about 5 to 12-year-olds here. So it is important to know our populations, know our data. Just kind of wanted to share those broad overviews to give us a sense of what we've been seeing. Let me just pause to see if there's any questions or comments in the chat. Okay, so I do want to highlight how Pennsylvania has placed a growing focus on youth mental health and suicide prevention through legislation. These certainly aren't the only relevant pieces of legislation, but these three are really helping to guide a lot of our efforts around mental health, safety, and suicide prevention efforts. The first being Act 71, which I think by now most of you are familiar with. The thing about Act 71, though, is it only requires the training for staff in grades 6 to 12, right? So that, and I know that many districts have actually gone beyond that grade range and are training all staff and are even training contracted staff and are really going above and beyond there. There is also, though, a student education piece. And that's something that I think was a little confusing in the initial legislation, that there is an expectation that students receive education on suicide prevention. And there are a lot of resources I'll be sharing around that. As far as Act 44, that is the legislation that followed the Parkland school shootings and really looked very comprehensively. It was the first legislation that had those big grants that schools got through PCCD and established Safe to Say Something. It required there to be a school safety and security coordinator in the schools. And something that a lot of schools are still kind of navigating is that it does require schools to assess their school safety. And that's both the physical safety of the school setting and something that we're primarily concerned with, the psychological safety. And schools are actually supposed to assess the extent to which they have school climate initiatives, behavioral health supports, and assess their student assistance program. And there are some approved assessors that are on the PCCD website, but schools can really go about this any way they want to. So you may have been seeing different pieces of this. That would be something to kind of look at and think about with your school teams if it's not something that you've been aware of. And then Act 18, that was focused on that model trauma-informed plan that was developed for schools to utilize and added trauma-informed education requirements for school personnel and some others. So this obviously goes hand in hand with our suicide prevention efforts, right? We aren't doing suicide prevention without being trauma-informed. So these pieces all fit together. And there are lots of resources, again, on the PCCD website. I can share some of those links if people are interested in looking at that. But a lot of the grants that have been ongoing coming out of PCCD have tied back to these pieces of legislation and asked schools to really think about and be intentional with using their data and what they're planning to implement with the grant funding. Also, what's not here, just to quickly mention, is Act 55, which was passed in 2022, which does also shift some of the focus and requirements around training. And so again, I really encourage everyone to take a look at those changes and requirements because it is a lot for schools to manage, but at the same time, these things do align, right? So how can schools be kind of tying things together and aligning efforts so it's not so overwhelming? Okay, so really what I'm gonna be doing a little bit later is talking about suicide prevention efforts by going across each level or tier of intervention, right? So focusing on universally, what can we be doing? And then focusing on the advanced tiers for supporting students that are at risk. But before I do that, I wanna just, if you're not familiar with some of these frameworks, I just wanna introduce them because the work of doing this in a comprehensive way is based on these frameworks. And it's based on kind of trying to operate, again, in a comprehensive way by tying these different pieces together. So I don't know if people have heard of Zero Suicide. I know we've done some work in Lehigh County with the current grant that I had mentioned. And just taking a look at the chat. And that's great, Kristen, that's awesome. Our SAP liaisons help SAP teams analyze their team and program effectiveness. Yep, and thank you for that plug. If you haven't received the effectiveness checklist survey, contact your SAP liaison. Great. I love that this is a diverse group because I feel like hopefully, any of the resources that you have to share, those connections you want to reemphasize, please do at any time. So Zero Suicide is actually a national framework and model. It is a systems approach that actually started in health and behavioral health care settings. So hospital systems, inpatient units are generally familiar with this model. The idea is that, and kind of where this started was that national data tells us over 80% of individuals who died by suicide saw a healthcare provider in the year before their death, and almost half of individuals that died by suicide saw a primary care provider in the past month. So those stats and data tell us that we should be doing more within those settings to identify individuals at risk, make sure they're connected to care. And the idea of Zero Suicide is what it says. It's an aspirational goal, but it's that we strive for zero, especially when we have someone that is connected to care. It really is a quality improvement initiative, and it is about looking at the needs and gaps in a system and looking at how we can work, again, more comprehensively and move to best practice. In schools, Zero Suicide hasn't necessarily made its way in, but there is a place for it. And in our current grant, we've really been working on emphasizing how schools are a perfect setting for a Zero Suicide approach. To break these down, these are the 7 components of Zero Suicide, and there is actually a whole toolkit online around Zero Suicide. If you Google it, you'll come to the website. I will say it's not really focused on schools, but I've been working with colleagues to kind of make that translation. Essentially, we're talking about having a leadership level of support for this, right? How do we prioritize anything if our leaders aren't bought into it? And then we're looking at all of these different elements. What are we doing for training, and what is best practice for training? Are we just doing a one-time training, or are we thinking about a training that is an evidence-based training and targeting that to the needs of the community and repeating that at regular intervals and tying that to our policy, right? So just to give you a sense, there's kind of like, there's tools through the Zero Suicide framework that help us understand what is kind of a baseline for this component and what is a best practice and how do we get there. We also need to have methods of identification, right? How do we identify someone when they are at risk? And then how do we engage them and keep them in, in the case of Zero Suicide originally, how do we keep them in treatment, right? If we translate this to schools, it's how do we keep them connected to supports? How do we monitor those supports, right? How do we engage families in that process? Again, we translate to, in schools, intervention strategies, supports, not necessarily formal treatment. That's what we're talking about in the treatment world. Transition is that moving between systems, and I'm sure that most, if not all of you, have experienced when an individual is at risk and they have to leave your system to get connected with another system, like crisis or an emergency room or an inpatient unit or an outpatient unit. And so those are warm handoff opportunities. Those are also, in Zero Suicide, they kind of have that Swiss cheese image. Those are where we see the gaps. Those are where families and students fall through the cracks. It's those transitions. So how do we strengthen those? And then finally, improve. So it's always about using our data, using data to drive decisions, looking at data, looking at our outcomes, and going from there. So part of the Zero Suicide framework and part of translating this into schools is this idea of upstream approaches. So the field of suicide prevention used to focus on individuals that were already at risk of suicide. It was all about, the individuals that were talking about suicide, that were in care, basically the individuals that were in the mental health system. But we've really gotten away from that. We know that the mental health system alone cannot solve our suicide prevention challenges. That this is something that if you do suicide prevention trainings or you've done this work, you know that it's everyone's business and that no one system, no one entity can do suicide prevention work alone. We've actually very excitingly seen at the state level in Pennsylvania that we've had a coming together of different agencies to collaborate around suicide prevention in general. We do have a statewide plan And if you haven't seen that, I have that in the resources as well. And it's not just, you know, the agency where I work, which is the mental health agency for the state that's involved in these efforts. It's also the Department of Education. It's also other agencies like the Department of Agriculture, right? Because we know that farmers and rural communities have increased rates of suicide. And so the Department of Agriculture has a vested interest in supporting rural families and farmers and the agriculture community around suicide. And so they have some dedicated curricular programs, trainings, and even a dedicated hotline for crisis for the agricultural community. So it is everyone kind of looking at this. It's PennDOT, right? So looking at our highways, our roads, looking at bridge barriers as a suicide prevention strategy, looking at billboards to advertise around suicide prevention resources. So again, we're looking at a coming together and also not just waiting until we're serving the populations that are already known to be at risk, but getting ahead of these issues as well. So what we know is that half of all mental disorders have their onset by age 14, right? And because mental illness is a significant risk factor for suicide, how can we get at the earlier risk factors and build those protective factors before individuals have even that onset of thoughts of suicide? And so it's not waiting, you know, the idea of upstream, it's not waiting till someone's already fallen into the river to help them, but going to the very beginning of that source and providing supports to help them understand, educate, you know, how do you swim, right? Putting up barriers so people aren't just falling in, right? And those other prevention strategies. And of course, schools really are the primary context in which to do that. So if you are a school person, you know the triangles and you know that it's hard to do any kind of presentation these days without a triangle here. I do realize this is incredibly small and I apologize for that. There was a lot that was packed into this. But probably more than 5 years ago, 6, 7 years ago, there were some efforts at the state level to look at how suicide prevention can be situated across the tiers of a multi-tiered framework. Okay, so just as we would do this for academics, just as we've done this for behavior in positive behavior supports and interventions, can we also do this for things like mental health? Can we do this for suicide prevention? And this particular image that you're seeing is looking at suicide prevention and how it aligns with PBIS specifically. But it doesn't have to be specific to PBIS is really what I want to say. And you don't have to formally be implementing PBIS to look at your suicide prevention efforts in this way. So it's just kind of getting us to think about what are we doing school-wide at a universal level for all students to basically create those emotionally and physically safe environments for students. That is the foundation for suicide prevention efforts. If we have a negative school climate, if we have a school environment where kids don't feel safe going to adults, right? That is an environment where it's going to have an impact on how effectively we can work to prevent suicide. It's not going to be as impactful if we have, you know, a suicide prevention training where we're encouraging students to confide in adults if we don't have those foundational supports in place. So I'm kind of sharing this to kind of set the stage. We're going to go through each level here and talk about what are some of the best practices and considerations for staff training at each level, for student education and supports at each level, and for assessment strategies and data collection at each level. Obviously, as we go up to more of the advanced tiers, we are looking at who are those students that may be at risk of suicide. So in the yellow, how do we support them? They don't have to have an actual identification, but if they have any kind of risk factor for suicide, and we know risk factors are many, right? What are we doing that may support those individuals? And then of course, in the red, we're looking at those students that are at higher risk of suicide, are at known risk, maybe have made an attempt, It could be any of those things. And we're looking at the same things at that level, right? What are we doing to train staff so that they can effectively support those students? How are we supporting those students directly through interventions? And then what are we doing to kind of look at our data and assessment strategies? Any questions so far? Okay, so I will keep us going. Before we actually move into the tiers of intervention, so before we get into like universal versus advanced tiers, there are some foundations that help establish readiness to do this work in a comprehensive way. I think if we're not paying attention to these foundational considerations, right? So things that need to be in place before we really dive in. And this is the same for any multi-tiered approach that you would put in place in a school. If you're doing PBIS, there's certain things you need to have as a foundation or readiness indicator before you just move in and start doing universal approaches. The same goes for things like comprehensive mental health and suicide prevention. Okay, so first, if we're thinking back to LEAD as the first component of zero suicide in that framework, that LEAD component that I talked about, you want to ask if there's buy-in and support for these efforts at the administrative level. That really does set the stage for the rest of the school community. If we are only checking those boxes of our legislation and saying we did this training, we did that training, we implemented this program over here, and if we're not thinking intentionally about how all of this work fits together, it is unlikely that these efforts are going to become part of the culture and norms of the school. And so that's something just to be mindful of, that administrative support really does help the rest of the school community have that buy-in. Administration also helps allocate necessary resources to things like teams. And I know that Act 71 talks about schools having a suicide prevention coordinator, or someone who can kind of oversee the work in the district or in the building. But ideally, we're working with our teams, and we're going to need our teams in any kind of multi-tiered framework. I'll talk about different places where we are going to need our teams, but this is, really what we're looking at as kind of a foundation and making sure these teams are functioning and understand what their role is when it comes to suicide prevention. You don't have to have a suicide prevention team. I will also just say that. I know in some of the new threat assessment guidelines that came out, it references like an Act 71 team. We know that schools get totally overwhelmed by the number of teams that they're expected to have, and it really does fall on the school to figure out where these teams can align and integrate. In fact, we have, from our SAP network, put out some guidance about integrating your SAP with your MTSS or PBIS efforts, right? And what that can look like. We know a lot of schools are looking at having different pathways and kind of combining teams in different ways or having staff that are crossing over between different teams. It's something, again, that has to be done very thoughtfully. But, I guess when I say team, I'm not putting out there that you have to create like a whole other team just for suicide prevention, not at all. Obviously, evidence-based and equitable practices, these are grounded in that data-based decision-making. So what data are we using to select the interventions that we want to have? Are we taking into consideration the student population they serve and the diverse needs of our student population? Two other pieces that go hand in hand are needs assessment and resource mapping. So in order to move forward and create goals around building up a multi-tiered or comprehensive framework, we want to start with something like a needs assessment. We want to understand the scope of the needs and strengths in the district or school related to mental health and suicide prevention. Some of you may have heard of the SHAPE assessment. That's one example. That's through the National Center for School Mental Health. And this is a starting point to clarify what those priorities are and how to action plan appropriately. So you don't have to reinvent the wheel. There are tools out there, they're free. Another tool that we're going to be sharing soon is that using the zero suicide framework that I mentioned, there's a self-study, which is basically a needs assessment, and it asks different items about to what extent you have in place different elements of lead and train and identify those components that I mentioned. And we've adapted that to school language. So schools can use that to look at their suicide prevention efforts and to help prioritize an action. Resource mapping, hopefully This is a familiar term to everyone here. I'm going to talk about it briefly in another moment, just in terms of how it relates to suicide prevention efforts. But essentially, we're looking to get everything down electronically on paper, however you want to. Electronically is probably easiest, but to avoid duplication, identify gaps, and help ensure that the options for strategies, intervention supports are accessible to all students, and that they're not just based on the knowledge of individual staff members. Like, we don't want individual staff members to be the keepers of a particular resource. We want everyone to know about that and how everyone in the school community can access that. When it comes to community partnerships, and I think Karen mentioned in the beginning, the task forces that you have across your counties, schools, as I mentioned before, no one agency, no one entity can do this work alone. As we go up in advancing through the tiers, you're going to be relying on partners to support your efforts, right? So who are those partners? Is there a system of care group? Is there a suicide prevention task force? Is there a United Way or local behavioral health agency? I saw the comments earlier in the chat about SAP and the resources that your SAP liaisons can offer to you as well. So find ways to coordinate and collaborate so you're not doing this work alone. And then finally, policies and procedures. The final foundation for doing this work, everything should be grounded in your policies and procedures. You should be able to circle back to these, review and revise these, and you need to be thinking about how this is shared back out with the school community. A recent change, of course, with Act 18 and the threat assessment teams is that your threat assessment efforts need to interface with suicide prevention efforts. In fact, threat assessment is now the umbrella term for threat of harm to self and others. So if you had a suicide prevention policy that you created for Act 71, there's a really good chance that you need to revisit that and have it interface with the new threat assessment guidelines for your teams. Okay, so just touching on a couple of the foundations, I'm going to talk about resource mapping, and then I'm going to talk a little more about policies and procedures in a moment. And then I am going to get into the actual, universal and advanced tiers. And I definitely want to hear from all of you at that point in terms of some things that you're doing. So I'm doing a quick time check. Okay. So with resource mapping, I'm curious if you have done this, if you want to add anything to the chat in terms of what this has looked like, but this is an ongoing process. Resource mapping isn't like a once and done kind of thing. You are continuously updating this or finding periods of time in the year that you're going to update this. And you can do this in different ways. You want to look at resources related to mental health suicide prevention within the school, and then also external to the building. And as you're seeing, there are some examples of that here, such as what are the available outpatient mental health services? Is there a mobile crisis team? What are the hospitals? Who are our partners in the community that we're collaborating with around suicide prevention and that offer specific supports and services to our students? And knowing, of course, that these change. But the reason you want to do this is because your teams are going to need this information to select, plan, and implement appropriate supports and services. Obviously, it's also grounded in data. So if you are looking at your PAYS data and it's showing that the district has seen continuous increases in students that are reporting suicidal thoughts and behaviors, right? Or if you're seeing trends by grade, like 8th grade girls are seeing the greatest increases in this, then you can be looking at resources targeted to a particular population and figuring out what can we offer in terms of universal strategies or even small group or individualized supports to help those in need. You might also map out your resources by tier. So what do we have universally, as I just mentioned, versus what do we have at more advanced tiers? And then again, you want to make sure that you're communicating these resources so that all staff know this information. Some districts and even, obviously at the county level too, are sharing these out with parents and the school community so that they can also know what's available and what to access. And, this is also a way to engage with your community partners, as I mentioned, because many counties have these lists. SAP liaisons especially may be knowledgeable and can contribute to helping to develop these lists and have this information. So perhaps the school team can just focus on internal resources. Okay, but either way, you do kind of want to have this as that foundation to helping the teams be able to function effectively. And then when it comes to your suicide prevention policies and procedures, what you're looking at here, so we're not just talking about the policy at the high level, which again, schools should have had from Act 71, prevention, identification, intervention. What's missing here is actually re-entry and postvention. And then your procedures are what actually translates those to what do we do step by step for these higher level policy indicators. Okay, and not only that, but I know, having worked with school entities, that yes, you get all those documents and policies you need to sign off on at the beginning of the school year, and you just kind of sign and go, right? But do staff truly understand and know what this should look like in practice? And how do these policies and procedures actually align with our implementation strategies? And I can give you an example of that. So QPR, right, question, persuade, refer, is one of the common trainings that many schools might look at for a suicide prevention training for staff. I've had a lot of conversations with schools when sometimes the training seems to conflict a little bit with what's written in policies and procedures. So many policies and procedures will say things like, don't leave the student alone. And as soon as a student makes a statement or shows a warning sign, they should be immediately referred to someone that can do, further identification of that student to see if they're at risk. Well, QPR as a training is promoting that conversation and that connection. So when you're training staff in QPR, you're encouraging them, because of the power of connection, to have a conversation with students and to take that moment, right, to connect, because that's such a huge protective factor. The message behind QPR is that a conversation can save a life, right? So you're training staff to have that conversation. Does that conflict with your policies that say that if a staff member notices a student, or a student says something, or they notice a warning sign, they should go immediately? So it's almost like deterring them from potentially having that conversation, right? So that's maybe something to reconcile and to think about. Another thing that I've heard a lot from schools is with screening for students at risk. And it may say in the procedures and in the policy that staff have to identify students. They should have a method for identification and maybe, screening. But a lot of times that's not fleshed out very much. So I've heard from schools where counselors across the district, or even counselors in the same building, are using different screening tools, right? Or maybe they're using a screening tool and it's not a standardized measure, or it's not a validated measure, which nothing in the law says it has to be, but I'm putting it out there really to suggest that it's something to think about. When different individuals in a district are using a different measure or tool, or asking their own questions in their own way, does that raise any concerns as far as, well, if that student went to this person, they would be asked these questions in this way. If that student saw this person, they might be asked these questions in that way. And what are the implications for identifying those students? What are the implications as well for supporting those staff members, right? Because this is a high risk, stressful, to say the least, situation. And so schools thinking about their actual procedures around screening can be really helpful, both in terms of standardizing the process, right, which is a protection when it comes to things like liability, but also a way to support staff so that, everyone is doing the same thing. We're laying out and developing those protocols. So it's not that it falls on you, completely. Not to say clinical judgment isn't a piece of this, but having that consistency to help staff feel more secure that they're following a protocol, as opposed to just, doing whatever they think is best, can be really helpful there. Okay, and so just a few other things that you're seeing here, of course, related to those procedures. All right, so I'm going to take a pause here, see something in the chat, And I do want to ask everyone if you would take a moment to enter into the chat some strategies, any strategy that your school or district or agency or organization implements universally. So something that you offer or provide to everyone, whether it's for staff, whether it's for students, and feel free to be specific if it's a particular intervention, training, whatever it is. Okay, so I'll give everyone a moment. I see, Wendy, your comment about CHC offering BH Works as a screener. Yeah, so if you're a school person, it looks like Wendy's suggesting that you contact your SAP liaison for more information on that. Thank you. Okay, so does anyone want to throw into the chat, or you can also unmute? I'll give it a second. Any strategy that you implement universally for students and related to mental health and or suicide prevention. So I'm seeing St. Luke's YES counseling program, Alveus, bullying prevention, SEL, school-wide positive behavior support plans, Navigate for risk assessments, mindfulness, 2-minute pause, which, sorry, things are coming in fast. 2-minute pause at the beginning of each block. Awesome. SEL team who administers weekly SEL lessons. It's wonderful. Zones of regulation, Shanti project, mindfulness class lessons. This is great. Threat assessment and suicide assessments are universal across the district. Great. SRSS universal screening. This is really wonderful. Thank you all for chiming in, and feel free to keep going. Bullying prevention. There's a lot that you're doing here. So this is awesome. And what I love about what everybody put in here is that it's not necessarily just super specific to suicide, but it's broader. And I think this really hits on the point that your suicide prevention efforts are all of these efforts. Because if we're looking at risk factors for suicide, we know that it includes things like bullying. Bullying is a significant risk factor, mental health concerns, all of these things, right? So when you're doing all these things in your districts, when you're teaching mindfulness and these really critical strategies for coping, right, and managing difficult emotions, you are equipping students with skills that they need for coping strategies and whatnot. And so that really is part of your suicide prevention efforts. You may not think of it that way, but that's definitely how I see it, and how I'm going to talk about things on the next few slides. So thank you for sharing all of those great strategies. Okay, and yes, keep them coming. When I see a VDM, so that will come up too. So just at the universal level, as I mentioned, what I do want to talk about is starting to lose my voice. I'll get through it. The training for the school community, okay, these other practices and programs to support skill development, like many of you already mentioned. And so that is the social emotional learning, the resilience education, anything we can do to help students build up those essential skills that we know they need to succeed in life, right? And then those school-wide initiatives to build protective factors and reduce risk factors. So when you're working on school climate, I don't know if I saw anyone mention school climate specifically, but school climate initiatives. I saw trauma-informed practices. So using these to kind of, again, mitigate risk and build protective factors. And then what data are we collecting across our school settings that can help inform these efforts? So we're thinking universal here. And I did see things like risk assessment, threat assessment, and how that's district-wide. So that makes sense that that's being thought of as universal here. When I'm going to talk about that, I'm going to talk about that more at the advanced tiers, because those strategies and policies and practices would more be implemented for a student at risk. So here I'm just talking about what is happening for kids across the board, even though those strategies are absolutely in place to be available for anyone. So I get how they would be thought of as universal. And really what we want to emphasize here is that it is not just the mental health professionals to do this work. And I know that's who we have a lot of you on this call today, and you do a lot of this work, but this is really for everyone. So starting with mental health literacy as a universal practice and approach. Okay, What do we mean by mental health literacy? It really is about increasing knowledge of mental health and suicide prevention. And it also has a goal of improving attitudes, right? We know how stigmatized these topics are. I think I'm preaching to the choir on that one. And it's building understanding about mental health disorders in order to support our prevention efforts, our ability to recognize and manage these conditions. As I mentioned, a huge focus is addressing the stigma. It's about awareness building. So for example, you see this PSA image on the right side of the screen. This is, and Karen mentioned some of the posters. This is, we have a high school PSA contest every year, and students across the Commonwealth, maybe some of your students, can enter and create a poster or a video or audio clip that gives a message of hope for suicide prevention and gives a resource, which just real quick, that is the National Suicide Prevention Lifeline. We've now shifted to 988, although that number does still work, but I just love this image. So I left this on here, even though the number has been updated. But we really want to help debunk myths about mental health and suicide when we do mental health literacy. We want to teach signs, and our goal is really to increase help seeking. So I did see some of you have in there QPR, right? So this is a little bit different than SEL. So SEL is amazing because it's teaching like those problem-solving skills and self-awareness and other foundational skills. Mental health literacy is really focused on building awareness and knowledge of mental health and trying to combat the stigma. So they do go hand in hand. So yes, a training like QPR would be more of like a mental health literacy type training, whereas something like Second Step would be more of an SEL program, and those obviously can go hand in hand, right? We really want to, and I know a lot of you are focusing your SEL efforts in the elementary level as those core foundations. And then as students are kind of growing a little bit older, as it becomes more developmentally appropriate to talk directly about mental health, suicide, things like that, those additional educational programs are being embedded at those points. Yeah, and I see, Jill, your comment, a challenge is to teach suicide prevention in an age-appropriate way in the elementary schools. Any suggestions to small children? So a couple of thoughts. So one would definitely be what I just said. I think that suicide prevention at the elementary level is very much about social emotional learning and helping students to build those foundational skills for problem solving, conflict resolution, emotion identification, help seeking, because those are the foundations for them to be coping more effectively as they get older, and to reinforce those messages early and build those skills early. It really is that, like, again, not suicide prevention directly, but suicide prevention indirectly. So I do think that's what it can look like at the elementary level. But I will say there are also some programs that have been developed free. I like to talk about free things. But I have some links to them later in the presentation, but Avidum, for example, which is, I'll share a little bit more about them. A lot of you, I think, do know them because I know they have a big presence in your counties. But most of us know about the Avidum clubs, which are awareness clubs. I think that maybe some of us aren't as familiar with the fact that Avidum has educational curricular programs that are free that you can download on their website. So they have actually created, like, for high school students, they have a curricular program on depression and suicide prevention. And then they also have it go all the way down to their Little Avidum program, which is appropriate for students as young as kindergarten, and starts to kind of introduce that language at a developmentally appropriate level. And then that can be built upon because they have leveled programs for middle school and high school as well. There's also, I think this came out of, it's either Connecticut or Massachusetts, but through one of their youth suicide prevention grants, they created an elementary curriculum that uses like a dog. I don't know if anyone's seen Gizmo's Possum Guide to Mental Health. I think that's the name of it. I could be saying it slightly off, but that is also a free educational resource that came from a youth suicide prevention grant, but kind of translates the concepts and uses like this cute puppy to kind of introduce some of these concepts at a younger grade level. So just to kind of highlight some of these strategies for mental health literacy, It can be about training, right? So we know things like QPR, More Than Sad, youth mental health first aid. Feel free to throw other ones into the chat, right? And all of these like educational programs for staff. But then it's also educating students, okay? And we'll talk about some of the evidence-based programs for students. And spoiler alert is there are not many, but things like the Avitum one I just mentioned and other ones that are out there, if they're not evidence-based, so to speak, from like the highest standard of a randomized controlled trial, these are evidence-informed. And there used to be the Suicide Prevention Resource Center, which is a national resource center for suicide prevention, as it goes without saying. They used to have a best practices registry where they had vetted programs. Some of them had that highest gold standard of a randomized controlled trial, but others were listed on there because they were promising practices or had been vetted by professional experts or were grounded in research. And so they were still there. So there really is a continuum when it comes to selecting interventions. And again, I'll talk about a couple in a minute. We also can think about these mental health awareness clubs. So do you have an Avitum club? And Avitum, again, for those of you that may not be familiar, it's an organization, and these clubs were started by students. Avitum was a term that was coined by a student that's a Latin derivative, meaning I've got your back. And it was students that were responding following a suicide of a peer and saying that we don't want this to ever happen again, what can we do? And so now Avitum as an organization helps schools put these clubs in place, because what it does is it helps with school-wide awareness efforts. The idea behind Avitum is that they want to create a school where every student feels acknowledged, appreciated, accepted, and cared for. And so what can that look like, and who better to help lead those efforts than students themselves? And so you can think about how this ties into mental health literacy and our climate efforts, because we're setting the stage here and we're getting that youth voice and that youth buy-in as a result. The other pieces of this are, how are we sharing mental health and crisis resources in a regular way? Like, how are we pushing this out there? How are we making this information available? So you can see how mental health literacy is about education, training, and it's also about climate awareness, destigmatizing. These are all kind of the pieces to be thinking about around mental health literacy. And finally, we do want to get away from those once and done trainings. How are, if we do a QPR, are we done with that? Or do we circle back to that at some point and help staff practice those skills? Ask staff, have you had a conversation like this? How did it go? What was challenging? What went well? Can we practice this again? Right? Not just kind of doing the once and done, right? And hoping that somehow it sticks. Apologies for another microscopic slide, but really what this is showing is that we do have a bunch of evidence-based programs at the universal level, and this is for suicide prevention specifically. There are some at the advanced tier level for individuals at risk, but not that many. And what I will say is most of these have not been evaluated through like a randomized controlled trial, as I mentioned, just a couple. Most of these programs, as far as their effectiveness, have looked at reductions in suicidal thoughts or suicidal behaviors, like a suicide attempt. Of course, none of these programs has been evaluated to look at whether they reduce suicide deaths. Again, for youth, even though we know there's high risk for suicide, death by suicide is still a low base rate behavior. Like statistically speaking, it's not a common behavior. So it's hard to look at those kinds of outcomes when we look at these programs, but I will call out a couple of these just to draw your attention to them. So signs of suicide, I'm not sure how many people have heard of signs of suicide. I will say that that is probably one of the most widely researched prevention programs that also has it's been replicated multiple times, and it's used randomized controlled trials to evaluate it. And so it showed that middle school youth that had signs of suicide were significantly less likely to report suicidal behaviors. And it also showed high school students had similar results. significantly less likely to report suicidal behaviors, and significantly fewer attempts. Besides the Youth Aware of Mental Health program, YAM, which you see a little bit below, which has been used more internationally and does have a lot of training requirements, can be quite expensive. There really aren't any direct suicide prevention education programs that have had as rigorous of research behind them. Not to say that they're not good, not to say they don't have solid content and haven't been vetted and aren't based on research, but just if we're talking about it from that research standpoint. The one other one that I will mention, because this is interesting, and I think this speaks to what we've been talking about, is that you see the good behavior game kind of towards the top, right below Cognito. And this is a classroom management strategy that the original research was actually done when students were in 1st and 2nd grade. And the authors had the foresight to make this longitudinal and do long-term follow-up, and found that the students that got this classroom management strategy, basically reinforcing students following classroom rules, that was basically in a nutshell what the good behavior game was. These students that had that intervention were significantly less likely to report suicidal thoughts and attempts when they were 19 and 20 years old, which is really remarkable than the group that didn't get this classroom management intervention strategy. So what does this tell us? I know that, as far as looking to implement the good behavior game, it's still out there. It's something you can implement. It's actually been expanded to the PAX, P-A-X, the behavior game, and there's lots of little kernels you can do. But my takeaway from this is that this is what some of the things that we can do, going back to that question, at the elementary level. This just reinforces that teaching those pro-social behaviors, reinforcing positive behaviors, teaching those skills at an elementary level can also be part of your suicide prevention efforts, because look at what the study found. So it just gives us something to think about when we implement PBIS, for example. We're not thinking about the long-term impacts of this. We're not thinking about this as suicide prevention, but maybe it is, right? And I think this particular intervention gives us a lot of reason to think about these other approaches that way. So I did mention our high school PSA contest. I think for the sake of time, I'm not going to pull up the website, but I really encourage you all to visit the website, because this is a really easy way to get that awareness piece into your efforts, because all of the resources on the Prevent Suicide PA website around this contest are free. I love this poster. This was the winning poster from last year's contest. This one does have 98 on it, so that's good. But this, so you can access this poster. All of the posters on the website are print ready. So you can either snip them, as you can see, I have them in my Zoom background as well. You can put them on your district website. If you have printing capabilities, you can print them, put them in your office, put them around the school, give them to your VDM clubs and have them do a campaign around them, putting them up or doing something creative that only youth can think of, not us as adults. But really use these is what I want to say. And not only these, but the 30-second videos, the 60-second videos, and the 30-second audio clips. Use them for September, which is Suicide Prevention Month. Use them for other athletic events in the school, and show a PSA before the basketball game, right? Like however you want to use these. We've had a lot of really creative ways that schools have done that. And again, it's another way just to push out this information, build that literacy, build that awareness of those resources. Oh, and just a quick plug. If anyone, I guess you would all be closer to Philly than Pittsburgh, but April 19th, coming up the weekend of April 19th, we have Suicide Prevention Night at the ballpark with the Phillies. And I think the Saturday night of that weekend, which is I think the 20th, same thing with the Pittsburgh Pirates. And the winners of this year's contest are invited. We're going to be tabling proceeds of the game, in part go to Prevent Suicide PA. And students get to see, students who were winners of this year's contest get to see how their message gets out to a large audience at a very large sporting event. So it's a really neat opportunity. And if you like baseball or you care about suicide prevention, maybe think about checking that out. Okay, so a couple more things here when we're still talking about the universal level. I had mentioned much earlier on about Peter Wyman, he, I don't know if I mentioned his name, but he was one of the kind of leaders of proposing this idea of upstream suicide prevention and doing this work in schools. And this study is possibly one of my favorite studies that I've seen. What he did, this was published in 2019, and really reinforces this idea of relationships and connectedness related to suicide prevention. So he used relational networking, where kids in schools, in high schools, were supposed to nominate their close friends and trusted adults. And they wanted to see how this related to reported suicide attempts in these high schools. They did this in 38 high schools. It was a randomized controlled trial. And what you're seeing here is how students' nominations of trusted adults, this is just comparing two different high schools, like two singular high schools. So students are in the outer circle. So school D, school E, students are in the outer circle. Staff are in the middle circle. And you're seeing that the circles are larger based on the number of nominations that were made. And then for the adults in the middle, circles are larger based on the number of nominations they received from students. So you're seeing some differences here, pretty obviously, right? School D, there were lots of trusted adults that were nominated by many students. So you see it's like many more connections, more dispersed around the circle. Where school E on the right, there were like similar numbers of nominations for the adults as far as like the size of them, but they were concentrated among many fewer students, right? And so the difference here when it came to the reported suicide attempts is that the students at school D, with the denser connections spread out among more students, reported significantly lower suicide attempts than the students at school E. So what we're seeing here is that, like, basically schools that had lower suicide attempt rates were those when the identified trusted relationships were more spread out among the student population. So this really speaks into the school climate piece, the connectedness piece, really making sure that that's a focus at the universal level. Again, we know it's an important protective factor, but this study tells us that it is a protective factor for suicide, and we see that very clearly in this research. So I can't underscore that enough as far as your universal efforts. Okay, so we've talked about training, education, other aspects of universal approaches when it comes to climate, connectedness, awareness, all those pieces at the universal level. Now I want to talk about data for just a second. And what are the sources of data that we can be thinking about when it comes to understanding the school-wide mental health and suicide prevention needs of our population? And this chart comes from a SAMHSA resource. It's linked at the bottom of the screen, and just gives us, that general indicator of all the range of data sources. Again, not exhaustive, but things we may want to consider. As we talked about with the PAYS, when we talked about things like students not enjoying being at school, or the percentage of teachers that don't stop bullying when they see it, right? Not all of these are direct indicators of mental health or suicide risk, but again, it is about looking at risk and protective factors, okay? So we could use things like classroom observations or school climate surveys, and those can give us indicators of how our students are functioning, how they're feeling about school, right? And we have other indicators that can help monitor students' progress. Even academic records can be an indicator of a student that may be at risk of a mental health challenge or at risk of suicide, right? So any of this can be tied to those larger efforts. I did see that someone put in the chat earlier that you do universal screening in your school. And I just want to take a pause here because I want to talk about universal screening for just a moment as a consideration for a universal approach to data collection here. So if you want to throw in the chat, if anyone else is doing universal screening, I'm curious to hear what tools are you using. And when I say universal screening, not so interested in the academics here, although I'm interested in academics, but not in this presentation here today. but more of the universal screening measures that you might be doing for behavior, social, emotional wellness, mental health. If anyone wants to throw anything in there real quick while I take a sip of water. Okay, the best screener. Any others? Okay, so Nicole administers the best K to 5. I'll give it another 30 seconds or so to see if anyone adds anything else, any other screeners. Again, I already saw the SRSS earlier. Okay, I will keep an eye on that on the chat. But what I will say about universal mental health or behavioral health screening is that it is a growing practice that has gained national attention. I did link on this slide to the School Mental Health Quality Guide for screening from the National Center for School Mental Health. There are a lot of resources. There is growing research on this practice. And this is about screening everyone, right? And I say everyone, but I mean, it could just be a certain grade level. It could just be a certain building, right? But in general, screening for mental health or behavioral health related challenges. And I will say that there is a lot that goes into this. So me talking about this today is not saying that every school should just go run and do universal mental health screening. In fact, it's quite the opposite. I want to make everyone aware of this and share a little bit of information, but I do also want to say that this really does depend on the infrastructure you have in place to do this. And so that goes back to the teams that are functioning, the administrative support, resource mapping, and knowing your available interventions and supports, right? You never want to screen without knowing you have resources to intervene. As a school psychologist, that was like the thing that was just drilled into me time and time again. Don't screen unless you can intervene. So lots of considerations if you're going to do this, but this can be a really, really helpful part of your broad safety net for identifying students at risk, and especially when it comes to internalizing challenges that we know that some students can hide pretty easily, and that we know that the objective, observable staff struggle with a little bit more than they do with more of the externalizing behaviors, right? So this can be something to really look at with your teams if you feel like you have the supports in place. And I will say it takes a lot of planning. So you're seeing some things here that would be some of those considerations for preparing for a screen, all the way from doing that resource mapping, getting consent, to planning step by step. What is this going to look like? How are we going to supervise students? How are we going to keep this information confidential? All the way to, how do we debrief? How are we going to use this data at an aggregate level? All of those different pieces. So there's a lot that does go into this. And part of this, of course, is selecting an appropriate tool. So we saw the best being used in elementary schools. A lot of the universal screening work that I have done has actually been done at high schools. And so instead of having teachers report this information, students would self-report this information, and then it would be followed up on accordingly. All right, there are different tools. There are broad-based measures. So I saw that put in about the BH Works. I forget who put that in earlier, but that's being used in SAP. There have been some school districts that have worked on that for universal screening, but again, with very careful planning and with partnerships like through SAP. But then I do also want to share, there was a large randomized control trial that really helped add to the research on universal screening that was done by Penn State Pro Wellness in Pennsylvania. So Pennsylvania high schools participated in this, almost 13,000 students. And this study used a depression screener, the PHQ-9. And so basically what they did was they randomized students by grade to either the control group, and that was basically like current business as usual, referring kids to SAP based on behaviors of concern, observable behaviors of concern. Okay, so just following those students who didn't get the screen and following them throughout the school year. And then they had a group that did get the screen, the PHQ-9. It's a brief depression screener that has one suicide screening item. And based on the screen, students were referred to SAP. And also they were followed throughout the course of the year to see if the screening helped increase the referral, whether in the moment of the screen or even later on. And so basically it was trying to look and see whether universal screening increased the likelihood of referral to SAP and the likelihood of students getting connected with a support or service. And as you can see from the graphic, students that screened positive on the PHQ-9 had 6 times the odds of being identified and referred to SAP compared to the group that was just business as usual. And ultimately, they had 2 times the odds of getting connected to a recommended support or service compared to peers that were not part of the universal screening. So what this tells us is that as far as identifying kids, especially in this case, it was really just for risk of depression. Bear in mind that screeners are not diagnostic. So this was not saying all these students have major depressive disorder. This was saying these students are at risk. Okay, but that doing a screener for an internalizing behavior like depression has the potential to increase identification and connection to supports and services. Okay, just checking the chat. When I mentioned universal screeners at a team meeting, the concern was teacher reporting at the elementary level and how perceptions of students change from year to year. Are there any reliable student report universal screeners for young children? So that is a great question. There are lots of screeners out there, but I think what you're describing is really just by nature of having a teacher report. Like I think for any, for any teacher report methods, of course, that's going to be susceptible to like their own observations, potential bias, all of that. And for student reports, I need to look into that a little bit further. I think just because of like things like reading levels and developmental levels at the elementary level, I'm trying to think if there are any offhand that I've seen in practice. I might have to look into that further, and I can put my contact information in the chat if you want to follow up after. There's none that are coming to mind right now, but I think that's also susceptible to, you know, having that reliability impacted because at the elementary level, right, students don't have that full self-awareness either. So you're kind of limited in terms of the questions you can ask. So in some ways, the adults in a student's life do tend to be more reliable reporters at that age. But anyway, that is a really interesting question. And yes, agreed. Hard to find a universal screening that takes into account special education or English language learners. And I know that with some of the screening efforts that I've done, you know, certainly could have an impact on validity, but have had accommodations put in place for some students. So for example, had a screener read aloud to a student or translated for a student, but again, just needing to kind of take into account the cost, benefit, and risk to validity and reliability. Some screeners have translated measures. So there are so many considerations here. I appreciate these comments because there's a lot to think through. And it's something that as part of my job, I do spend a lot of time on. So seeing these questions, if you do want to reach out and talk further about some of these challenges afterwards, by all means, I'll give my contact information and keep putting some comments in the chat and I'll try to get to those. Okay, so I'm looking at the time. We don't have a lot of time to get through some of the targeted and indicated approaches. So I'll try to move quickly through this, and I definitely want to see if I can end a few minutes early to see if there are other questions. But basically, what we're talking about now is what additional training do specialized staff need? And when I say specialized staff, I'm mostly talking about all of you. You're the specialized staff. So this is not just the 101 QPR youth mental health first aid training, right? This is like the additional training that you all may need to effectively identify and support students that may be at risk of suicide or have known suicide risk, have attempted, etc., or have known mental health challenges that significantly impact their day-to-day functioning, all of that. What targeted trainings may you need? So that's something to think about at the advanced tiers. And then of course, how are we identifying students? And I know a lot of you already put in there your protocols, pathways for suicide risk assessment, threat assessment. We'll talk about that. Looking at group and individual interventions and supports. So I'll ask and be curious what you have in place at that level. And then crisis response. So we can't forget about these essential protocols for crisis response. And this not only includes suicide, homicide, this includes larger scale crises that may affect our school community, because we know that being impacted by a traumatic event increases risk of trauma and could potentially lead to some of these other issues. So having effective crisis response to mitigate that traumatic impact is part of these advanced supports. And then as you're seeing, just reiterating the box on the right, all of these are resting on these foundations of effective teams, data collection, all of these pieces that we've been talking about. So want to briefly just talk about what are these referral pathways. Okay, so it could be direct referrals to services and supports, but really that's a direct access approach, or the team process is referring students when there is a concern to a school-based team. Obviously with this group, SAP is a good one that comes to mind, but it doesn't have to be a SAP team. There are many other teams, right? The threat assessment teams, other crisis response teams, things like that in the school that might also be looking at these referrals. I will say it gets overwhelming, right? How many teams? How are we routing these referrals? This is kind of what I was talking about earlier, where schools are trying to look at their teams, and there are tools out here, not the one linked on this slide, that one is about referral pathways, but there's tools like teaming inventories, where you can literally take an inventory of all the teams in your school, talk about who is on them, what does this team do, how do they make decisions, and looking at the overlaps between teams to try to figure out where things can be aligned to be made more efficient. Whatever you do, you want to make sure that the referral process is effective, as efficient as possible, and you want to make sure that it's transparent so that students and families know about how to make referrals, staff know how to make referrals, and it doesn't slow down the ability to connect to supports in a timely manner. Okay, it doesn't mean that schools can make referrals directly if they want to. I think what I want to emphasize here is that there's benefits to using a multidisciplinary team. I think sometimes in schools, teams get frustrated by a team process because it feels like maybe it's delaying the referrals, or maybe it's delaying a needed service. But on the other hand, we know that when we go through a team process, it's systematic. We're collecting data. We're using that data to make decisions, so we have more confidence that the referrals that we're making are grounded in data and are appropriate. And it also helps us consider a broader range of options. And I can give an example. We have a guidance document about school-based outpatient and how SAP can help with that. And going through the SAP process means that, again, we're ensuring the appropriateness of that referral, but we're also giving families choice. When we make direct referrals to one place, we're kind of forgetting about that importance of giving options and choice. We're also missing that team process, which helps us to think about if a student's going to need treatment or support outside of the school, there's probably a good chance they may need some support inside the school. So going through our school teams to kind of make those external referrals can help ensure that there's that monitoring and accountability. Okay, we may also need to be having these students on the radar for a 504 plan or a special education evaluation. So it keeps everything systematic and documented. Okay, but ultimately at the end of the day, the important thing is figure out your referral pathways, make sure these are clear, and make sure you're sharing these so that people in the school community know how to make a referral. I don't think I need to spend a lot of time on this with this group, but what I will point out is, I just mentioned the SAP process. We are looking at changing some of our language around these phases. And so you might see some differences in language here. We're working on a training revision for SAP statewide. Again, I don't think I need to speak into this so much for this group because I know that this was all brought together with SAP in mind. But just to let you know that there's lots of resources, lots of things being updated and looked at. The guidance document on schools and outpatient providers in schools using SAP, that is on our website. We also did a recent evaluation of SAP, looking at our SAP data over a 5-year period. And we have a study that's on our site. We also have how can SAP align with MTSS. That's on the website, so please go and check those out if they can be helpful to your team. Okay, so if we could quickly throw in the chat any advanced tier, so advanced tier, I mean like small group, individualized, any types of supports or interventions that you have in your schools that relate to mental health or suicide prevention. This, again, this list is not exhaustive, but throw in the chat. I'm just curious to see a few examples of some of the things you all have in place. And I will say, just in briefly looking at this list, most of the school-based interventions at the advanced tiers have definitely focused more on externalizing behaviors than internalizing problems. So I will say that as far as internalizing ones, that they're sometimes limited. There are ones like Coping Cat and Coping Koala, if you've seen those, CBITS, right, which is focused on trauma. And these are not exclusive to suicide prevention, again, because we know that trauma, for example, is a significant risk factor for suicide. So having CBITS, right, if you're identifying that some students are at risk of trauma or have been impacted by trauma, and you implement something like CBITS, a cognitive behavioral intervention for trauma in schools, that is potentially part of your suicide prevention efforts, as we've been talking about, because you're getting at that significant risk factor of trauma with that intervention. I'll call out a couple of these. Oh, and thanks, Lauren. So Resilience Builder Program for Children and Adolescents, Coping Cat, Skill, oh, more coming through rapidly, so I lost that one, but I think I saw Bounce Back, a wellness center, Peace Room, Moravian OT Partnership, Resolve, great. Lots of really good ones, and keep throwing this in there because I really like to see what schools are doing at the advanced tiers. But I will call out a couple of these. So for example, some of these are designed to actually be implemented across the 3 tiers, like DBT Steps A. I'm sure most of you have heard of dialectical behavior therapy, which is an evidence-based treatment for suicide risk in a clinical therapeutic setting. But Mazza, Jim Mazza, who developed this with his wife, Elizabeth Mazza, he is a school psychologist, she is a clinical psychologist who studied under Marsha Linehan, and they worked together to basically extract the skills from the DBT framework. So mindfulness and distress tolerance, right, things like that. And they translated them to universal small group and individualized interventions that can be taught in school. So actual skills that can be taught in school. Another one here is the positive family support or family checkup. That is designed to reduce substance use and behavior problems. But actually, when they did an evaluation of this, they actually found for 6th grade students, when they were engaged in the family checkup, it was associated with reductions in suicidal thoughts and ideation, as well as suicide attempts. So you have some of these other programs that might have a different focus in mind, right? But again, because the risk factors for suicide and protective factors are so broad, you may be impacting the risk of suicide by looking at these kinds of programs across the board. And yep, and I see, that's great. Okay, I love what's being put in the chat. Thank you. Okay, so looking at suicide risk screening and assessment, I have on here some examples of assessment tools. So this is what we're thinking about at the advanced tiers when it comes to assessment. We want to have those methods of identification. There's lots of tools out there. There's some that are validated, standardized. The Columbia is looked at as in that way. The Ask Suicide Screening by Horowitz is looked at in that way. And there's some others that are standardized, but maybe haven't been rigorously evaluated. Some of you may be familiar with Terry Erbacher's tool, the Youth Suicide Risk Screening Form and the Assessment Form. So these are just some of the ones that I've seen used in schools. I know some schools do develop their own tools, which is a consideration. And, as long as those are used consistently, I think that is something to keep in mind. But is there value in kind of looking at a tool that is standardized and validated in the research literature? At a minimum, I know there's actually some, we could probably talk for the rest of the time, there's some controversy happening now at the national level coming out of the American School Counselors Association about whether school counselors should screen, and pointing to some concerns about liability if so, and mainly because of concerns about training to do so. So here's what I would say. The general national feedback to that in response to that has been that schools have a responsibility to identify students at risk. It's part of Act 71, it's part of Act 18 with threat assessment, and the liability really comes into play from hearing from experts on that when schools don't do anything as opposed to doing something. And these laws really do ensure that schools put something in place. Some schools are going to do a briefer screen, some schools are going to lean more towards a comprehensive assessment. I would say that the bottom line is you want to make sure that staff are comfortable and confident in what they're doing. And if they need more training for a screening, we actually have some free trainings on our online learning center, and I'll share that link. Assessment is much more in depth and really does require much more extensive training. So think about whether that's necessary, or many schools I work with really just need to make that decision of, one of my colleagues calls it the no or go decision. So is this at the level of risk that we need to have a student get further evaluation and send them outside of the school for that? Or is this a student that we can continue to support, collaborate with the family, and keep in school in this moment? So these are all lots of considerations. I feel like this slide could probably be its own training, but really just want to draw attention to how this is part of your comprehensive suicide prevention effort. Relatedly, Act 71 and the model policies talk about safety planning, so I'm not sure whether this is something that you're doing. But this is, kind of a standard safety planning tool. There are some resources that have come out about safety planning for younger students and what this can look like. And essentially what you're doing is helping to create that tool that can help build that student's independence when it comes to helping to manage a crisis. So you work on this collaboratively with them, it's shared. Anyone that's in the safety plan should know they're in the safety plan. We don't want to have people listed in there that would be someone the child would go to when they're at increased risk and that person has no idea, right? And so we want to work with students to create these. We also know that sometimes students have safety plans from an outside provider. So if you have releases, you might be sharing the safety plans between school and external to school. Really, this is a big coordination piece. We want to reinforce consistency across environments as much as possible. We don't want students to have a safety plan that they created when they were discharged from inpatient and then come to school and create a safety plan and those two plans don't mesh, right? That's just confusing to a student. So this also brings up, we're in the advanced tiers. We're needing to collaborate with our community partners as much as possible. And I know easier said than done sometimes. I know there's lots of barriers to that. But just things to be thinking about. Okay, let me check the chat. Yeah, the American School Counselor Association recommends we not perform risk assessments at all. If we are required to, that we say we're unable to assess accurately due to student self-report and recommend referral. Yeah, they say the data on safety plans shows they're not effective. So I think this is, I guess without getting too much into this for the rest of the training, I know that this is a big area of national discussion right now. A lot of our national suicide prevention resource organizations and advocacy groups and research groups are having conversations with the American School Counselors Association. I guess what my message would be is that schools have a responsibility to identify students that are at risk. And so these are things to be thinking about. I know that most of the research on safety plans has been done with adults, but there's very, very strong research in support of safety plans. I think the field is looking at how can we translate these to youth, how can we build the research for youth. But at this point, as far as an individualized intervention, there is strong evidence that is supporting it. So that's, just for purposes right now, but I know that the conversations that are happening are causing a lot of concerns. I think that it's, looking at the chat again, so basically they mean that anytime a student is referred for risk assessment, we should never say they are not at risk and should just refer out. Yeah, I think that that's, again, I would say that these are conversations 100% to have internally with your teams. I would say, you know, include your solicitors in some of these conversations because it does come back to your school's policies and procedures. But as far as what our state does mandate from our legislation, schools should have methods of identification. If that's something that the school feels strongly a school counselor shouldn't do, there are other school professionals, school mental health professionals that may be able to do that. But again, you all have the connections with students. You all know these students best. I'm sure many of you have had the experience, if not all of you, of identifying a student that is at high risk and referring them for further supports, and that student not sharing the types of information that they were willing to share with you. I think part of the controversy is also around communicating level of risk. So level of risk isn't stable. And I think some of the feedback is that that's information gathering. We're using this to gather information. We're not using this to determine level of risk because that can change at any time. And we need to be mindful of that. We know that suicidal thoughts can wax and wane. There's clinical judgment that goes into this, but there's also ways to be trained to be effective in doing this too. So I think, again, we could definitely go down a rabbit hole, but for the most part, I think the concerns are around liability when we don't do anything, as opposed to when we have some way to gather information, get a sense of where that child is at, and put supports in place for them and have collaborative communication with our other partners. So I'll leave it at that for now, just so I can kind of keep going with the time that we have left. Another thing that when schools are looking at documentation and data at the advanced tiers, I know that typically when we do screen or assess, we keep that in our individual files, of course, for confidentiality purposes, but we never look at it or use it in any other way. And something that schools are wanting to do, again, to be more proactive in their efforts, is to find ways to track aggregate data when they see a student in crisis. So instead of that just going in a file to never be seen again, is there value in kind of tracking on some sort of spreadsheet some of these indicators? And let me give you an example. We do often hear from schools that the majority of students that they might refer out to an emergency room or hospital do not get admitted. So, okay, is that something that can be helpful for us to look at as a team? You know, can we actually pull those numbers? Can we track the number of students that we screen that we then refer out? And can we track whether those students get admitted? And so does that give us valuable data for our school team to be able to have conversations about, could we be collaborating more with these external partners to figure out how are they making decisions when students come to them? Or could we be looking at some of our screening processes? Does it tell us we need to look at our screening protocols to make some changes because maybe we're not using a consistent screening tool? Maybe we need to look at that first. Or when we look at aggregate data, does it tell us that, hey, we're seeing a really high percentage of 7th grade girls that are coming to us in crisis this year? Do we need to put added supports in place for that grade level? Or do we need to do more prevention work before 7th grade? So there's ways that I think schools are trying to just keep better track of this data, being mindful of privacy and confidentiality, but finding ways to kind of aggregate how many kids are we seeing that come to us with a crisis-related concern and what are the outcomes. We also know at the advanced tiers that these could be students with very high risk, at known risk of suicide, students that may have attempted. I'm sure many of you have worked with students that have expressed ideation in a repeated way. And so I wanted to just highlight that maybe there's opportunities for monitoring of these students. And in Erbacher, Singer, and Poland's book, they do talk about methods for ongoing monitoring. So for example, finding out what a student's baseline is. Some students are going to have recurring ideation. And so if a student's baseline is at a 4, and then you're seeing them for a screen and they report that they go up to a 6 in terms of the intensity of their thoughts, right? That might be very telling, as opposed to a student that comes to you day and day again that is consistently staying at a 4. For them, a 4 might be one thing, whereas another student's baseline might be a 1 or a 2. Kind of knowing your students, and they share some of these tools for ways that you can monitor them, with suggestions that you can even graph where they're at based on these tools and look at changes over time. So you can start to see when these thoughts might be intensifying beyond a baseline, and come up again with a plan for how to support the students when that happens. I guess a couple quick things I will just end on, which I don't want to be quick with these, but I know we're kind of coming to the end of our time here. The last 2 pieces are really around reentry and postvention. And I know that reentry can be quite challenging because so much depends on whether you know that the child was hospitalized and that they're coming back to school. But schools can still have policies and procedures for reentry and do again, it's sometimes doing the best you can with the information you get. I've definitely heard from some schools that when they've established these policies and protocols, when they've communicated these to families, and in fact talked to families about how the school can support the child upon coming back to school, that they do end up having more families being willing to share information. I think sometimes, and what I've heard from a lot of stakeholders across different counties, is that usually when families are asked to sign a release of information, the person that's asking them to do that isn't explaining how it could be helpful to them or their child. So they're not explaining that the school can support them, that there's a SAP process and things like that. And so families don't know why it would be beneficial to share this information, and they don't see why a school, right, would need to know this information. And so I think a lot of this is communicating with those stakeholders, especially because what we know is that when families have youth at risk, they are often bearing the burden of those transitions in care and getting that information from here to there and following up on services. So, there's also strategies that I am hearing are happening in different counties around communication going directly between schools and outpatient. Schools and inpatient. So for example, an inpatient unit having a contact person for every school in the county to kind of streamline their ability to reach out when they have an admitted student and to collaborate. Again, with appropriate signed releases. And things just to bear in mind for this is, having that reentry meeting, we know that the students' perceptions of what they need is valuable, and asking them what their preferences are. Do you want to share this information with anyone? If so, who? Right? If they want to share, do they feel comfortable talking about this, or do they need to practice it? What do they want to share? Do they want to share, these details or just that detail, right? So obviously there are other supports and strategies that schools can put in place. And so having a reentry plan is about the short-term supports and the monitoring. Sometimes schools feel like they have to go right to a special education evaluation process, whereas the student may just need some supports for a couple of weeks to transition back in. So the purpose of this plan is to be that short-term support, to gather data to monitor, and then to see if the student has transitioned successfully, or if they're going to need any additional supports in the longer term, at which point schools can consider these other longer term approaches. And then finally, for schools that have been impacted by a death, especially a death by suicide, that is just not something anyone wants to experience ever. And firsthand all of the many, many pieces that go into a postvention response. When schools don't have these plans in place ahead of time, it does come down to scrambling in the moment, and in a moment already of crisis, and then scrambling to figure out what to do makes things that much harder. So there are several resources for best practice in postvention. This is part of your prevention efforts, because especially when it comes to suicide, we know that youth are susceptible to contagion. So if you don't have postvention procedures in place, kids are at increased risk when a suicide does happen in the school community. And that's not just kids that knew the student that died. It's other kids that may be vulnerable. And a school response can really impact how, the course from there. I will also say that postvention is not just like a week, right? It's a more extensive response. It's iterative, it's ongoing. There's likely going to need to be monitoring for, months to come, let alone anniversaries of a significant event and whatnot. And then there's other pieces to this, like memorials that, they might not come up immediately, but they will come up. And so questions like, does your school have a memorial policy? Because the conversations around things like memorials are often very emotionally charged. And if you can fall back on a policy, it gives you just a little bit of foundation for that discussion. These are all challenging conversations. And so just some things to be mindful of as you're looking at this. And I will mention that the PREPARE model is a framework for crisis response. There are lots of other frameworks for this, but we are doing a kind of a statewide initiative around the PREPARE model. Just actually did a couple trainings in Lehigh County around PREPARE. And there's resources to implement trainings elsewhere if that's something that you are interested in. And there's lots of information on the National Association of School Psychologists website. Couple resources real quick, and then I'll look back to the chat. But the SHAPE system, which is by the National Center for School Mental Health, it gives tons of resources, including just that general SHAPE needs assessment for schools to look at their infrastructure around supporting mental health, and free. So I encourage you to go there. They also have lists of screening tools, assessment tools, all kinds of training resources, tip sheets, webinars, many more things through the National Center for School Mental Health and tools within the SHAPE system itself. I had mentioned our Suicide Prevention Online Learning Center. So we have free suicide prevention trainings for educators. You just have to register on that website, pspalearning.com. There's trainings that can help meet the state mandated training requirements that are free. We also have more advanced trainings or specialized trainings for all of you that are specialized staff, things on self-injury in teens, about developing effective safety plans, even assessing and managing risk in suicidal youth. And then we've been continuing to partner with the PA Parent and Family Alliance. So looking to build out resources with them. There is a tip sheet here. How do I talk to my child about suicide? So if you're working with a family, it's like a one-pager. It's in English and Spanish, and you can give it to families. It's developed in partnership with families to be parent-friendly and really help give them some pointers in how to navigate that conversation. And we're continuing to work with them. One that we're looking at is what parents need to know about a child's inpatient stay. So that's one we've heard parents could really benefit from some more support and information around. And then I just want to mention like the groups in Pennsylvania, VEDM, the Jan Marie Foundation, the University of Pittsburgh. All of these are links to information about free resources. I'm a big proponent of free. So trainings, educational materials for students, the postvention standards manual for schools on postvention, and then even the STAR Center has an annual conference and they record all of their webinars. They did a great one on Black youth suicide. The other year, they did another good one on safety plans for pre-adolescents. So lots to check out there. And then just our crisis resources, state and national, and some other resources. And here's my contact information. So I might have a couple minutes to spare, Karen. I can look at I will share the slide deck with Karen to send out to everybody. I'm just looking at the chat real quick. And yes, Jen, I see your comments about, yes, absolutely, the communication gaps between schools and other entities. And I know in our current grant, that's something we're really working on, is kind of bringing systems together to have some of these conversations. Like, you know, we have a county that the crisis organization reaches out to schools at the beginning of every year to ask them, do you want to meet? Are there any questions you have? Can we talk about, you know, our system, your systems, like how we're making decisions around these things? So, you know, any opportunities to engage with those partners and have those conversations outside of the moment of crisis. I know that's hard because we're pressed for time, but I think could be very valuable. And Kristen, thanks for adding those links. There's some awesome things going on. I think we're pretty much at time. Any other final questions? And otherwise, I just really thank you. It was just really great to spend 2 hours with you on a Monday morning. And I know it was just like a lot thrown at people, but I appreciate all of the amazing work that you're all doing in your counties and your schools. And I just, every day I appreciate what you all do. So if there's anything I can help with, please don't hesitate to contact me. And I hope you have a great week.
So we'll be listing the survey link. Participants, if you please complete the survey, you'll get a certificate for your participation. Give us 1 second.
It's in the chat.
Okay, I didn't see it.
Let me put it again. I have put it in the waiting room with the participants. So let me.
Okay. There we go. Excellent.